So it's my pleasure and honor to introduce the next speaker, Professor Anna Ong-Lim. Professor Ong-Lim has more than 20 years of experience in pediatric infections and tropical diseases. Following acquiring a doctor's degree from the University of the Philippines, she completed her residency in pediatrics, followed by a fellowship in pediatric infectious disease from the Philippines General Hospital, University of the Philippines. She currently serves as Professor-in-Chief of the Division of Infectious and Tropical Disease in Pediatrics at UP-PGH. Professor Ong-Lim was at the forefront of Philippines' COVID-19 management efforts and served as a member of the National Technical Advisory Group, as well as the Interim National Immunization Technical Advisory Group for COVID-19 vaccines. Her involvement in national vaccine policy continues post-pandemic through the work around formation of the country's NITAG. She likewise serves as a member of the WHO WPRO Regional Commission for Certification of the Eradication of Poliomyelitis. Professor Ong-Lim is extensively involved in clinical trials for pediatric vaccines. She's a member of key infectious disease associations, including the Infectious Disease Society of America and the Asian Society of Pediatric Infectious Disease. She has authored several publications focused on pediatric health and infectious disease and is a regular speaker on these topics at scientific congresses. Dear colleagues, let's all welcome Professor Anna Ong-Lim.
Thank you, Dr. Josie, for your kind introduction. It's a pleasure to be with your team this afternoon and to have the opportunity to discuss something which I think is of real importance for our part of the world. Dr. Chu has already given us quite a extensive background and discussion about vaccine acceptance and vaccine hesitancy and put this together with the Hong Kong experience. And I'd like to take off from his topic by now going into some evidence-based approaches to address the problem of vaccine hesitancy. So what I'd like to do for the next few minutes is to go through these 4 questions very quickly so that we are all on the same page to discuss what vaccine hesitancy is, what's the extent of the problem, why it happens, and finally, how we can help. So hesitancy, one way of approaching hesitancy is to think about it as we think about disease conditions. Because to be able to solve the problem, there needs to be an understanding of the magnitude and the setting. There needs to be a diagnosis of the root cause. Then this leads to evidence-based strategies to address the causes, and then eventually some kind of monitoring or evaluation to determine whether the intervention was successful. So this is very important because vaccine hesitancy is not just one condition. It has many interrelated determinants. And by assessing it in a systematic manner, by exploring individual or group or context influences, as well as vaccine or vaccination-specific issues, this will help us make a diagnosis which should differentiate between barriers related to acceptance and access. So this was already alluded to earlier in Dr. Chu's discussion, but I'll expand on it a little more as I go through. So the first major instance of discussion of vaccine hesitancy from the global health perspective actually came in 2014 through the SAGE definition, which talks about vaccine hesitancy as a delay in acceptance or refusal of vaccination despite the availability of vaccination services. But further on, after a decade, the WHO also convened a behavioral and social determinants of vaccination working group, which tried to understand this problem a little better with the experiences of the past decade. And they say that it's not just simply this particular aspect of not being vaccinated, but rather it's a motivational state of being conflicted, where you are either conflicted about or opposed to getting vaccinated. And this recognizes hesitancy now as an intention or a motivation that's separate from resulting behavior. So, for example, we may have been very hesitant about being vaccinated with the COVID vaccine at the start of the pandemic. But as Dr. Chu said, eventually people decided to be vaccinated anyway because they could not go to restaurants, they could not access public transport, they could not go to work. So there is a separation between the motivation and the intention and the behavior that follows it. And now understanding that this is not just delaying acceptance or refusing, but rather a motivational state will enable the behaviors and the influences of the behavior to be better understood and to be measured separately. So this diagram shows us a very nice illustration of the continuum of attitudes and behaviors. There are people who don't have any issues with vaccines whatsoever and actually are very interested. They demand to be vaccinated. There's some who take it as a part of life. For example, for parents of young children, they know that polio vaccination is important and they will agree to having their children receive polio vaccines. There are also a group of people that whatever you do to convince them, they will not be vaccinated. They refuse all sorts of vaccines. What we're talking about is this group of people who are hesitant, who may accept some, who may refuse some, or who may delay some of these vaccines that they are being offered. So this is complex and very context specific and can vary across time or place or even with relation to the vaccine. So with this, we have to understand that vaccine hesitant individuals are a heterogeneous group. They have various degrees of indecision. It is not a one-size-fits-all label that says a person who is vaccine hesitant about one particular vaccine or at a particular point in time will forever be vaccine hesitant. And that's really why we need to constantly work at understanding this subgroup of individuals or these communities so we can tailor fit our approaches. So what is not vaccine hesitancy? It does not apply to situations where the uptake is low because of logistical considerations. There's a lack of available services or the vaccines are not available. So hesitancy can be present, but that's not the reason why the uptake is low. There may be concerns about safety, which may be associated with hesitancy, but safety is only one of the many drivers of hesitancy. Communication is also a key tool for success, but it is not a specific determinant in vaccine hesitancy because, for example, there may be inadequate or poor communication about particular vaccines, why they're recommended or why they're safe or effective, but people choose to be vaccinated anyway. So defining the scope and differentiating other factors for non-vaccination is very important so we can assess which interventions are going to work and what are needed. So having gone through the question of what vaccine hesitancy is, now we're ready to look at what is the extent of the problem. So although this is something that we are debating at the moment or discussing quite actively at the moment, resistance to vaccination is not a new problem. It's been present since past centuries. And in the United States, for example, in the 1850s, where smallpox vaccinations were made available, mandating vaccination for smallpox was seen as a violation of liberty. There were anti-vaccine movements that occurred in the 1970s in the United Kingdom where they questioned the efficacy, rather the safety of wholesale pertussis vaccines. And of course, the current trend towards vaccine hesitancy has been ascribed to the Wakefield publication where the link or a link between autism and the MMR vaccine sparked a worldwide crisis. So although vaccine hesitancy has been a problem for centuries, the major difference now really is the presence of the internet, which allows massive diffusion of information, not just by well-intentioned people, but those who are actually intentionally providing misinformation. So It's therefore not surprising that the World Health Organization actually named the vaccine hesitancy as one of the major threats to world health in 2019. And even after going through the COVID pandemic, it continues to be one of the major issues that global public health needs to work on. So what has happened since the pandemic? There has been continuing decline in global vaccine confidence, where the WHO and UNICEF 2023 State of the World's Children report found that confidence in childhood vaccines declined in over 50% of surveyed countries post-pandemic. And in a study published in The Lancet looking at vaccine confidence between 2015 and 2021, this decline was observed in 1/3 of the countries surveyed, with the most significant drops found in young adults between 18 to 34 years old. There has been documented increased hesitancy in developed nations, where in the US, routine coverage among kindergartners fell below the target 95% in 2024. In the UK, the uptake of MMR fell to 84.5%, with the lowest levels, or which are the lowest levels in a decade, and are resulting in an increase in measles cases in 2023 and 2024. And in France, there's persistent skepticism about vaccines, especially among adults under the age of 40 years. In the Asia-Pacific region, vaccine acceptance is diverse and dynamic. It can be high and stable, for example, in countries like Vietnam, Japan, and South Korea. It can be moderate and uneven in India, Indonesia, and Malaysia. It can be worryingly low or declining in the Philippines and parts of South Asia. And in the Asia-Pacific regions, there can be varying degrees of acceptance, where in Australia and New Zealand, initial uptake was strong, but in the Pacific Islands, there is variable acceptance. This map shows us a snapshot of the World Vaccine Confidence Index. And this is a visualization of the work of the Vaccine Confidence Project, which is a team headed by Professor Heidi Larson, and which is housed in the London School of Hygiene and Tropical Medicine. It is a tool for gaining data-led insights into vaccine confidence at different levels, and it uses standardized methodologies and questions to examine individuals' perceptions of importance, safety, effectiveness of vaccines. And so for each of the questions in the questionnaire, you will see a visualization of the map. Now, this map happens to be the representation for the question of, do you believe that vaccines are important for children? And you will see here that for the countries involved in the survey, most, if not all, will agree with that statement. So that's how to use this tool, and this may be something that the audience will be interested in. It's important because it helps us have a picture of where to prioritize confidence building. And I'm glad to say that since this project was started in 2015, where certain parts of the world showed really high hesitancy, that current trend seems to be more acceptance. So let's go to the next question of, why does vaccine hesitancy happen? And understanding that it is a behavior will help us figure out why there is even vaccine hesitancy in the first place. So vaccine hesitancy is influenced by factors like confidence or a lack of trust in the vaccine or provider, complacency, which is a perception that we don't need the vaccine, it's not important, there is no such disease in my community or my country, so why is that even necessary? And finally, there is a question of convenience, which lumps all of the logistical considerations together. Can the patient go to the facility to be vaccinated? Is the schedule compatible with his work schedule? Do they have the transportation fare to be able to go to the vaccination center? Is the vaccination center well stocked? And so on and so forth. No? So these are some factors that can actually contribute to vaccine hesitancy. So confidence is reflected or affected by levels of trust in the vaccines, in the delivery system, and in health authorities. Complacency is affected by the perceived risk for vaccine-preventable diseases and vaccination, where other life and health issues may have a higher priority. And finally, convenience is impacted by barriers related to geography, availability, affordability, and acceptability of services. Now, over time, this model has been expanded from 3 to 5 Cs, where confidence, complacency, and convenience are now joined by a collective response or altruism, the willingness to protect others, and social norming. Everybody in the community is vaccinated, therefore I should be vaccinated. And also calculation, which is seeking information before making decisions as to vaccination. The problem, particularly with this last issue of calculation, is that since or even before COVID-19, there have been deliberate attempts to disseminate wrong information to undermine the public health response and advance alternative agendas, with mis- and disinformation being propagated and definitely causing harm to people's physical and mental health, increasing stigmatization, and threatening health gains. So finally, with that particular background in place, having a better understanding of what vaccine hesitancy means, how wide or how broad is this problem, and what are the factors that cause it to happen, we can now go to the last question, which is how can we help? Now, although researchers have developed many tools for understanding the prevalence of vaccine hesitancy and the factors that drive it, moving forward towards scalable, effective strategies is really going to be a very complex undertaking, because vaccine decisions are made across the lifespan, can change over time, they're very individual, and often take place within the context of personal experience with vaccine-preventable diseases. So, for example, if I happen to have a relative who died because of dengue, you can expect that my response towards the availability of dengue vaccine would be more favorable compared to somebody whose only experience with dengue vaccination has been hearing media reports of potential harm. So these are very individual experiences that can affect or impact our behaviors. Now, many interventions and strategies focus on supporting provider and patient communication and building a culture of immunization support. But one common thread in all of these recommendations, strategies, interventions is an emphasis on the role of the individual clinician as a trusted source of vaccine information and advice. So we are told as healthcare professionals that our communication should be presumptive. We do not ask whether our patient is willing to be vaccinated, but rather we inform them that so-and-so person, you are now scheduled for vaccination and you are receiving the flu vaccine today. So this holds true even for parents who express vaccine hesitancy or who do not plan to follow vaccine recommendations. It's very important to remember as healthcare providers that we have the power to make these recommendations, and we need to utilize this power consistently and effectively. So the Wellcome Trust released this publication that looks at effective interventions to increase vaccination rates. And they once again emphasize that factors affecting whether or not people get vaccinated include practical issues as well as social norms, personal beliefs, and what we think and feel about the risks and benefits of vaccinations. But these factors are also interlinked, and when we come up against inconvenience and practical barriers that prevent us from getting a vaccine, this makes us feel even less likely to take the vaccine once it becomes available. So their recommendations are to remove the practical barriers to vaccination and to build resilient systems, make sure that access is not going to be a problem, and realize that simple solutions can have a huge impact. For example, phone call reminders can actually increase vaccination appointments by almost 20%. it's also important to change the way we talk about vaccine hesitancy. All throughout this talk, I've been using that term, but really, the phrase is very easy to misinterpret. And in some circles, the language or the terminology that is preferred now is vaccine acceptance, because hesitancy can actually overemphasize the threat posed by low vaccine confidence and just stop the conversation at that point without exploring other factors that can really help improve vaccination uptake. It's important to be specific about the barriers we're encountering. It's not vaccine hesitancy when the problem is there's no vaccines available. It's not vaccine hesitancy when it is inconvenient to be vaccinated because the schedules don't fit my lifestyle. So these are very important to specify so we can address these problems directly. It's important, once again, to strengthen the voices of healthcare workers in presenting vaccination as a social norm. So what does it mean? Once again, we presume that, or we have to specify, we have to state that a person is going to be vaccinated rather than to ask whether they will be vaccinated or are willing to be vaccinated or not. This presumptive, this recommendatory tone is very important and has been proven time and again by research to make a difference in terms of uptake. Finally, it's also important to address the research gap. Most of the available research still relies on evidence coming from high-income settings, and it doesn't really reflect what our problems are in our part of the world. We have cultural norms that we have to respect, faith-based, specific beliefs that might be impacting on our acceptance of vaccines, and this should actually reflect on how we address issues of vaccine acceptance in our part of the world. Finally, let me just share this recommendations coming from a publication that was shared in Academic Pediatrics under the title of What Works to Increase Vaccine Uptake. So observational studies show that thoughts and feelings are correlated with vaccine uptake. However, it's very curious to note that interventions that change thoughts and feelings actually increase vaccine uptake. So what does this translate to? This goes back to my example about being hesitant about COVID vaccines and yet being vaccinated at the end. Many of us, or we know many people who may have had their reservations about being vaccinated or receiving the COVID vaccines. But in the end, they opted to be vaccinated because they tell us, my workplace won't let me come in unless I show a proof of vaccination. I cannot take public transport unless I show proof of vaccination. I cannot travel out of the country if I don't have a COVID vaccine certificate. So all of these did not change their feelings about being vaccinated, yet they had to receive the vaccine. Social processes are important to take advantage of because social norming, altruism, and sharing through social media can impact on positive vaccine acceptance. Once again, referencing the experience of the COVID pandemic, we know many people in the public, in the community, waited until influential individuals in their countries were shown to have received COVID vaccines before they themselves opted to be vaccinated. This is the same way also with HPV vaccines and all other commonly accepted or commonly administered vaccines. Whenever we see a public figure being vaccinated, it improves the uptake in many cases. Interventions that directly change behavior are reliably effective ways to increase vaccine uptake. So you may not be able to change the way they think or the way they feel or their social experience, but by giving reminders, setting defaults, or putting in vaccine requirements, then it is possible to increase vaccine uptake. And finally, and once again, coming from or mimicking or re-emphasizing what has been shared in the previous two recommendations that I also mentioned, healthcare provider recommendations are still the most potent intervention for increasing vaccine uptake. So I hope my presentation has helped us to answer these 4 key questions of what is vaccine hesitancy, how big of a problem is it, why it happens, and how we can help. And I'd like to leave you with this quote from Professor Heidi Larson, who I mentioned is the team lead for the Vaccine Confidence Project. She says, never assume what is in the minds and emotions of people when it comes to vaccines. But we also shouldn't forget that they can still change. Thank you very much.